So you're all very welcome, talking about hospital overcrowding today and health systems that help us with that. Very relevant in this day and age. One thing I've been struck by over the last couple of days is how universal this problem is. So many different healthcare systems affected by the same problem, this hospital overcrowding issue. If you don't have a hospital or an emergency department with patients on trolleys, you'd be the exception. So maybe if that's you, we can learn from you today. But very interested to hear what our speakers have to say. I'm Bryce Wickham. I'm an emergency consultant here in Wexford Hospital in Ireland. This is my co-chair who will introduce himself.
Yeah, my name is Abdul Safras. I'm one of the consultants in emergency medicine and major trauma from Cork University Hospital. It's about an hour from here. And delighted to have you all in Ireland. And we have a very interesting title today. So we all are coming from different health systems, but we have one common thing, which is overcrowding. So it'll be really exciting and interesting to hear all your talks.
Great. All right, so we're going to kick it off. I have the absolute pleasure of introducing our first speaker, James Phillips. James Phillips, you may recognize from CNN as being their informant on all things COVID. Very distinguished man, has a lot to say, and is worth listening to. James is from the George Washington University. Do I have it right, James?
Yes, sir.
And he's going to be presenting to us today on the topic of his choice, which I will let him introduce.
Thanks, man. All right, good morning, everybody. There was a lot of karaoke and Guinness last night, so forgive my voice. So I'm very excited to be here today. I'm going to be talking about a topic that has pretty much nothing to do with hospital overcrowding, so you can have that for the rest of the time. What I want to talk about is something a little bit near and dear to my heart, and something that is more in line with what has been the topic overall of WADEM this Congress, which is about terrorism. And I got a bit of a unique perspective, I think, when I take a look at what's going on in the world and how we should be preparing in our emergency departments and our cities, and from the United States. It's obviously going to be from that perspective, but I'll try to keep it as universal as possible. So I want to talk about the fact that I think that in the recent years we've undergone a paradigm shift in terrorist tactics, and how does that affect us? What does that mean for us in emergency medicine and how we do our jobs? So back in 2016, when I first started sort of researching these topics. I was just finished my fellowship in disaster medicine in Boston. I was the new director of counterterrorism medicine at Beth Israel in Boston, and started really exploring the concepts of what was going on. So I asked myself this question in a lecture, and these are actual slides from 2016. I said, what is the future of terrorist attacks in the United States? Near and dear to my heart, because in Boston, 3 weeks before I started my fellowship, the Boston Marathon bombing occurred. I'm born and raised in a place called Oklahoma, which is known for a few things. In particular, whenever I was in high school, we heard a large boom, and terrorists blew up a 13-story building in Oklahoma City back in 1995. My father was the first firefighter in the building. It was the formative moment of my career when I was 17. So I asked this question, what is the future of terrorist attacks? And I answered it, and I said, in 2016, the future are lone wolf attacks with firearms and improvised explosive devices, IEDs. And that was what I believe to be proximity bias, because I had just experienced this bombing. Both bombers came through our emergency department in Boston, and numerous victims. And so I think I was biased because I don't believe this anymore. So what do I believe now? Well, everything changed about 2 months after that lecture, when someone hijacked a lorry and drove a 19-ton truck down the Promenade des Anglais during Bastille Day and killed 86 people and injured more than 400 others. Police were able to eventually stop the vehicle, but not before untold damage was done. This changed everything, in my opinion, because it was shortly followed by major attacks all around Europe and even in the United States, from Berlin, 2 attacks in London, or 1 in Westminster, 1 in London, 1 at an outdoor seating facility, dining facility in Germany. Toronto was affected. Here we go to North America. And of course, New York had several attacks as well, this being one of them. But so why do I bring these up now? Why is this important? Well, because I ask myself now, what do we even call these attacks? Right? When I started doing research on these and noticing this pattern, I was trying to learn more about how to even do research on it. What do we know about the injuries that occurred during them? Who are the people that are doing it? How do we better prepare our cities and our events? But I couldn't even figure out how to research it, because is it a vehicle ramming, a car ramming, a truck attack? You couldn't find it for a search term. So I took it upon myself to come up with one, and I hope that you agree that it fits. So what I coined is a tarmac attack, and these are targeted automobile ramming mass casualty attacks. Rolls off the tongue, and it's very well defined. It's not defined, however, by motive, which is important, because not all tarmac attacks are terrorist attacks. Motive is not what we do. Motive is for law enforcement. I'm a physician. My job is to understand injury patterns and how to save lives. The term can be used universally and includes all intentional events. So what is the origin of tarmac attacks? In the middle of the decade, Al-Qaeda was still pretty active, pretty widespread, and pretty focused, unlike it is now. They had an online propaganda magazine called Inspire Magazine. This is not only the magazine where the Tsarnaev brothers from Boston learned how to make pressure cooker bombs in order to blow up the Boston Marathon bombing, but in fact, they had articles that tell you about how to make a vehicle attack. But it wasn't Al-Qaeda alone. ISIS had their own online propaganda magazine called Rumaya. And in 2016, they also put out detailed instructions on how to make your vehicle more deadly. And they even showed targets. That's the Macy's Day Parade in New York. So you can imagine the amount of preparation that had to take place after these were found online by our intelligence folks. But it's important to realize that even though these instructions are from ISIS and Al-Qaeda, not all tarmac attacks are terrorism. PCP, as a drug, caused this gentleman, not this person, but the guy in the vehicle, to try to commit suicide by cop. So in Times Square, he committed an intentional tarmac attack to try to get himself killed. This is my university back home in Oklahoma, at Oklahoma State University. At our football homecoming parade, in the morning before that, for a still unknown reason, a girl in her mid-20s just took a left turn and crashed into the crowd. She was sober and she was sane. She killed a number of people, injured even more, and this was during, the biggest football game of our year, where hundreds of thousands of people are there to enjoy. And even just last week in Texas, a man of unknown motive and unknown sobriety at this time seems to have intentionally crashed his car into a group of migrants seeking aid at an asylum station. Now, when it comes to injuries that we see from terrorist attacks, we're well versed in that. Everybody in here has read about blast injury ad nauseum. Those of you who have seen combat have probably experienced it. So we're used to Boston Marathon bombing. We prepare for that. The Oklahoma City bombing, train bombings, Mumbai. These are the sorts of projectile injuries, a sort of sharp trauma where missiles enter your body and cause cavitary injury and bleeding. We're trained in that. We know how to do that. But what makes tarmac attacks unique is it's the only type of intentional mass blunt trauma. So that's why it's important that we study this to find out, should we be preparing differently? This is different. This is a paradigm change, not only in tactics, but potentially also in the injuries that we see and how we care for them. I won't read too much physics to you because I'm a doctor, so I don't have to do math, but we all know momentum is mass and velocity. And that's why when you saw those magazines, they talk about using big trucks, a 19-ton lorry that was hijacked, moving trucks from U-Haul and from Ryder. But not everybody does that. One of the more famous tarmac attacks in the United States was in Charlottesville, Virginia. Now, I live in Washington, D.C., which you may not know, that's basically Virginia, okay? And my wife taught at the University of Virginia here in Charlottesville when this occurred. Freedom of speech, right? So you can be a neo-Nazi and a white supremacist and have a rally. You're allowed to do that. And that's what this was on the campus. And you also have the right to counter-protest that. So there were large counter-protests of groups also in the Charlottesville area. And unplanned, from a dead stop, this gentleman who was part of that rally gunned the accelerator on his Dodge Challenger into a crowd of counter-protesters. It was well recorded, well documented how all this happened. It was a very short drive. It was nearly a city block, maybe less than that. I've been there, I've walked it. But you can see the damage and destructions that he did to the people that were not expecting it. When that happened, I finally saw the opportunity that I was looking for to actually try to study this, to actually try to get real data. Because if you've ever tried to get patient privacy data from another country, like France or Germany, good luck. I thought the United States had strict rules. So I haven't been able to get any of that information. But my team, we sought out to be able to figure out how to start doing research on this, and in particular on the Charlottesville attack. And I actually was able to present that here yesterday. But what we really want is more data. We want international data, not only demographics and data on the attacks, where they occur, what vehicles, the weight, the momentum, the understanding behind potentially the motive, but also what we really want is to get the data so we can start analyzing how we can better prepare and better treat our patients. When I searched through the Global Terrorism Database, the Global Terrorism Index, again, not only is there not a search term that you can use to find these types of attacks, but it was included in with like truck bombings and car bombings and any sort of vehicle attack. So I took it upon myself and we created the Global Tarmac database. Now it's been since the pandemic hit that we've really started to update it, but we feel very confident in the data that we have that shows that these were intentional events only, that were covered globally, and we can show a clear trend even before the terrorist propaganda came out, but clearly there was a change whenever the Al-Qaeda magazine came out, and then again when the ISIS magazine came out. And this is important because this is a trend. And the only ones we included here were 3 or more deaths, when that death didn't include the person committing the crime. And that's just our definition. It can be a different definition. But what's important to note is that these are global. These are happening everywhere. It's important for me back home to let people know that this is happening all over the United States as well. And this was data only up until 2019. What we certainly noticed after the Charlottesville attack, which was widespread and really got a lot of attention in the United States, is that this was something we needed to pay attention to. Like I said, we were able to get data. I didn't include the slides that showed the different orthopedic injuries, the number of operations, the number of interventional radiology procedures, the length of stay in the ICU. All those demographics, we finally have it, but it was only on 19 people. So we need more data when these occur. Now they are occurring in the United States again. So since the data that I presented in those maps, during the George Floyd protests, which is a collective name that we use for the Black Lives Matter protests that started in the United States a couple of years ago and accelerated through the pandemic, which were in response to police brutality against Black Americans. And unfortunately, during these times, we also noticed that one of the protest techniques tended to be, as it usually is, gathering in large crowds, but recently it's been blocking highways and things of that nature. And unfortunately, when you are in a large crowd in the street, that makes you a soft target. It makes you a target of opportunity, and you're a soft target, like I said. And so we started to see a tremendous uptick in the number of people that these were probably crimes of passion. These were not necessarily premeditated, but they were certainly terroristic. And we saw this enormous uptick where we were seeing 5, 4, 3 a month, or per day as we were moving along. And this was unprecedented. There were over 100 during that time frame, whereas globally there'd only been like 30 or 40 that we included. So it's definitely a trend that's moving upwards, and we need to prepare. So how do we prevent them, right? We know we love our disaster cycle. We want to prevent and mitigate and prepare. So mitigation is the key here. This is outside the White House. This is the executive office building, which is next door to the White House, which is right down here. You can't drive down that street. Why? Because of these bollards. If you don't know what they're called in English, they're bollards. And what they are is these things go far deeper into the ground than you might think. These will stop a vehicle, and that's what they're designed for. And if you don't design your building with bollards around them, you're putting yourself at risk. The reason that the Oklahoma City bombing happened, a right-wing terrorist decided to blow up a federal building in America, and they scouted out several states. And they chose Oklahoma. It was completely untied to any of their beliefs, but there were no bollards outside. So they were able to drive the truck directly up next to the building and detonate it. That's the only reason. So protection is the key with these. So anti-tarmac bollards come in all shapes and sizes. These planters, these ones over here, when you go to like a target and there's a big red ball so you can't get into the target, all of those are designed to prevent vehicles from getting in or getting close. If you don't have those permanent structures, there's also the temporary structures. There's a number of different anti-tarmac technologies that have been developed. They're all expensive. We don't have any of the budget for that. But they exist and can help prevent these things, whether they're spike strips or things that launch your vehicle into the air and break the transmission. They all work, and they can stop big trucks. But you've got to deploy them strategically around whatever event you might be having outside. In DC, we do it differently. We keep it simple. We use snow plows, we use MRAPs, we use military vehicles, we use dump trucks. And these are huge rallies. This one up here, I think I was medical director for all of these events, actually. This is fun. The one up here was the March for Our Lives, which we had 850,000 people in the streets. We won the Major League Baseball championship that year, and we won the Stanley Cup. And we got to have those parades in our streets. And so this is the easy, low cost. You can use a city bus, but this prevents it. Colin Clark, who's one of my favorite terrorism analysts, wrote this just recently about what he believes to be the future of terrorism. And I think it's interesting because he says the defining feature of international terrorism in 23 will be its diversity. And the reason he says that is because back home, we're worried about the rise of right-wing extremism. It's scary. And I know I'm biased because I'm from Oklahoma City and I've felt it myself. But terrorism has been democratized. It's easy to do. And that leads to the trend. The everyday extremists that want to make the world burn and think that they can get that started by going out in a blaze of glory and killing a bunch of people, that's what accelerationism is. And we're starting to see radicalization online in our own country, which is very frightening. So here's the paradigm shift. The crown jewel for terrorists from the 70s and 80s and 90s is the American airline industry and the European airline industry. You take down a plane, you hijack a plane, you win. That was the crown jewel. It proved that you could beat any security, you could do anything. 9/11 was the ultimate win. But things have changed because as terrorists learn tactics, law enforcement learns tactics. And you can see this trend that attacks on airports and airplanes have diminished significantly. Particularly 9/11 was an aberrancy, but it's not the target anymore because it's too hard. And what you can even see here is that suicide attacks have started to decrease globally as well. And the reason for this is because of the about intelligence and law enforcement that's made it harder to do these. Both of these types of attacks were sort of the predominant, prototypical type of terrorist attack are high complexity. They require material that's hard to get, maybe even illegal. They require conspiracy. It requires technical expertise. Might require flight lessons. Requires people who are willing to give their lives to do so. That's the paradigm change because we don't see that anymore. Now we see two different things. First and foremost, in the United States, where guns are ubiquitous and there's more guns than there are people in our country, we're seeing the rise of mass shootings. And motive aside, not all of them are terrorism, but many of them are. And what's the definition of terrorism anyway? I always say if you ask 100 people their definition of terrorism, you'll get 105 answers because everyone says it differently, but the same basic things apply. Regardless, the AR-15 and assault rifles are destroying my country. And it is it's a serious issue that we're dealing with, and we're not dealing with it seriously. In addition to that, these mass shootings are a trend for terrorists. We see San Bernardino, where there's been true inspiration from jihadi terrorism that has led to these shootings in our country. But that's not the majority by any means. I showed you earlier this trend going up in tarmac attacks. So we can see what's going down, we can see what's going up. So is that a paradigm shift? Yes, it is. So if I ask myself that question again, what is the future of terrorist attacks in the United States? Is to low-tech, homegrown, violent extremism against civilian soft targets using firearms and tarmac attacks. Low-tech being the key. What does it take to commit a tarmac attack? Keys to a vehicle. That's it. You don't even really have to know how to drive one. All you gotta do is push the gas. What does it take to commit a mass shooting? A weapon. You can buy one at Walmart. And so that's the paradigm shift, is both in philosophy from high tech to low tech, and in tactics from bombings to tarmac attacks and shooting. So we need to be prepared. Consider whenever you're revising your emergency operations plans for your emergency departments, for your cities, for your states, remember to think about vehicular ramming attacks. Call it tarmac, call it whatever you want. Just make sure that you're planning for it. Whenever you're having an event in your city that you're planning for, make sure that the first thing you're thinking about is protecting the footprint of your event to prevent someone from coming in there with just a vehicle and killing a bunch of people. Thank you guys for your time. I know this is a little bit off topic compared to hospital crowding. I have many opinions there too, but I have a limited time. So thank you guys for your time. I hope you enjoyed.
That's fantastic, James. Well done. I really like what you had to say about protecting the footprint of the event. It's really a great way of thinking about it. So we're going to be moving on. James is going to be with us the rest of the afternoon or the rest of the session if you're interested in asking him some questions about this later. But moving on, we're going to be hearing from George Tell from Italy on mapping nurses' advanced roles in the emergency departments globally. He's presenting instead of his colleague Alessandro Lamberti. So please, if we could have George Tell up. There we go. Welcome, George.
Thank you very much. I'm waiting for the slides to be on. Yeah. So, good morning, everybody. We now go back to the original topic of overcrowding.
5 minutes.
My name is George. I come from Italy, also from Romania. I'm a PhD student in criminology. I'm very passionate about disaster medicine and everything around it. Today I have the pleasure to present you a work that has been done by my fellow colleague, Alessandro Lamberti Castronovo, who unfortunately, due to personal reasons, couldn't be here with us, regarding the nurses' advanced competencies in emergency departments at a global level. There is a lot of literature supporting the overcrowding that we also see in our hospitals, and besides the overcrowding, we also have massive problems with the shortage of healthcare workers around the globe. For example, only in Italy in 2021 compared to 2020, there was an increase of 39% on the number of people, of healthcare workers, leaving the emergency department and the national health care system to go and work somewhere else or in other domains. After COVID-19, the European Commission planned and issued this National Recovery and Resilience Plan, which is a European plan, multi-billion plan, addressed at the national level, focused on several domains, including healthcare. Under the healthcare umbrella, one of the main components were the strengthening of community-based health services and reassessment of the healthcare workers' competencies in order to ease the burden on the healthcare system. In Italy nowadays, there are several regions who try to understand how to change the competencies of the nurses, how to introduce advanced competencies for better healthcare preparedness. Therefore, we wanted to understand if there is any scientific evidence behind advanced competencies for nurses. We performed a scoping review in 2023, February, using 3 keywords, which were nurses, overcrowding, and emergency department. Using these, we screened 4 different databases, and we included original articles addressing emergency department in high-income countries. Why that? Because we wanted the health systems to be comparable to Italy. And the articles had nurses at central stage in the article, in the central spot. When I'm referring to advanced competencies, I take the normal day-to-day competencies of nurses in Italy as a baseline. After the initial search, we had around 3,000 articles, and following the PRISMA for scoping review, we ended up with 102 articles included in our study. As a result, we found 3 main advanced competencies that nurses have around the world. Firstly, the first one is the clinical management of patients. Second one, advanced triage, and they are able to request basic imaging and lab exams on their own, autonomously. And the third one is the flow management of the patient. In terms of the clinical management, we were pleasantly surprised to see that if nurses have SOPs well-defined, if they are trained in a standardized manner, and if they have minimum 3 years of experience, they can treat minor injuries, minor illnesses in the emergency department without any problem, like urinary retention, urticaria, with very positive results, not only in terms of quality, but also safety of the patients. In terms of advanced triage, the fact that nurses can order on their own lab exams, they can order x-rays, decreased not only the length of stay for urgent cases, but also in some particular cases, for example, asthma exacerbation in children, it decreased the hospitalization rate. In terms of flow management, not only that the nurses did a very good job in managing space in the emergency department, but also there was a high grade of satisfaction among both patients and staff. As a conclusion, giving the nurses an advanced role in the emergency department is safe and efficient if there are clearly defined roles, well-defined protocols, and of course they receive adequate training and, if needed, support from the senior figures. We think that the way forward is through big multicentric studies that address this topic and also qualitative studies addressing the barriers of implementation and possible solutions in terms of advanced roles for nurses. Thank you very much. Here are our contact details. We look forward to any questions at the end of the session. Thank you.
Thank you. Thank you very much, George. So we'll move into our next speaker, Linda Katirji. Linda is a consultant in emergency medicine from Kentucky, USA.
Hello, like he said, my name's Linda Katirji. I'm one of the emergency medicine physicians at University of Kentucky, and I'm going to talk to you guys a little bit about some of the failures of our initial response at University of Kentucky Hospital to the COVID-19 pandemic, and a few successes as well. So, University of Kentucky healthcare system and the college is in Lexington, Kentucky. And it's kind of that red county in the middle there, so kind of in the middle of eastern Kentucky. It's a relatively smaller city in the United States with a population of 300,000, but still has a pretty big population for Kentucky in general. The Kentucky population has some differences from the rest of the country that make it unique and also challenging regarding the pandemic. So it's a very rural state, other than Lexington, where I'm from, and Louisville, which is the other larger city in Kentucky. Most people live in a rural area. So greater than 50% live in a rural area, or what is defined as rural, versus 25% in average in other states. And the population density is pretty low, so around 500 per square mile, whereas the rest of the US is almost 3,000. Additionally, Kentucky is a very conservative and white working class state, so we have a higher percentage of people who are non-Hispanic white, a very high percentage of people who lack any kind of college degree. We have a high percentage of evangelical Christians and people who voted for Trump, which kind of comes along with certain political beliefs that made restrictions during the pandemic challenging. This is a graph of, again, Kentucky, and the point of the whole thing really is just showing you how many people lack any kind of college degree. So you can see in the middle, the darker blue around Lexington and Louisville, a higher percentage of people do have some sort of bachelor's degree or college degree, but the lightest blue and the lighter blue counties have less than 10 or 10 to 15% with a college degree. So most of the state, again, has lower education level, and kind of the unemployment trends also follow that as well. So low education, low health literacy in most of the state. So in March 16th, our governor of Kentucky issued a shelter at home, essentially, closed public schools, and then businesses, dine-in restaurants and things like that. And again, because of the specific population that we have in Kentucky, this was pretty challenging. So long story short, the restrictions worked in Louisville and Lexington and did slow down the spread of COVID, so people did shelter at home, shelter in place, but there was no detectable effect of these restrictions that were put in place across the rest of the state, so kind of that lighter blue, more rural towns. So essentially COVID spread as it would have without any restrictions in most of the state. This kind of wordy, but really just to show our mortality rate though was pretty on par with the rest of the United States, but the United States again was higher than the rest of the world. This graph shows the blue is the cases per week starting from January and then up until the end of March of this year, or January of 2020 till the March of this year. And then the orange is weekly death rate per 100,000. So you can see that we had high deaths but low cases in the very beginning of the pandemic. And then we essentially had two large peaks in both winters of 2021 and 2022. So our hospital specifically, this is where we work, University of Kentucky Healthcare. It's a pretty big hospital, again, not very many large hospitals in Kentucky. We have over 120,000 ED visits per year. We have 1,000 beds. We take a lot of transfers from small rural hospitals. And so it's a pretty big, well-resourced hospital. We got this email on March 6th of 2020. The first patient in Kentucky had COVID and was in our hospital. And so everybody freaked out immediately. And then we would get emails like this, every day, basically showing us how many people had COVID, who was on vents, things like that. So there was a lot of panic at first, and especially when we didn't know kind of what we were doing, a lot of kind of misuse of resources and things that delayed care. So we had the first case in the beginning of March. We couldn't really test until the end of March, and even then, the testing was long. It didn't come back. We didn't know how to deliver the results to people. And the hospital didn't take action and canceling elective cases and things that would help until much later in March and really even later in the year. So like I said, we're a pretty well-resourced hospital. Our rooms are nice. We have a lot of technology, and we were lucky in that we never ran out of PAPRs or PPE like N95s and things like that. We did have to ration things, but we were lucky and we didn't have to deal with those. Our initial response in the emergency room were just to kind of staff with extra providers. We made like hot and cold areas for COVID. And this created also just a lot of confusion in the beginning and slowing a process. Like I said, testing was longer and things like that. We did a lot of unnecessary tests in the beginning, and I'll kind of show you a couple of those. So again, very wordy, but I just point out this was our initial process in how to treat COVID patients we were evaluating for COVID. And so really, the things that I think are important is that we were swabbing everybody for every viral URI. And if that was positive for anything other than COVID, we kind of assumed they couldn't have COVID as well, which in retrospect was dumb. And we were also scanning everybody's chest as well, which was a huge waste of resources and money if they didn't need it for other reasons, and kind of slowed down everything too. So this was our protocol for kind of low risk people. So obviously if they needed to be admitted, we admitted them, but you can see kind of up in the corner there, we would try to get labs to risk stratify people and sometimes not really know what to do with them, and then needed a lot of social services to kind of figure out if people were able to quarantine, and that was very subjective. Again, STEMIs, we, instead of doing primary PCI, if they were stable, they got thrombolysis as well. So they got substandard care if we were worried about COVID. The point of this really is that this was for codes or cardiac arrest, and the most experienced providers and everybody were outside of the room. So theoretically, these people may have gotten less care as well. I'm gonna skip over that. The biggest thing that our hospital kind of did that was a failure was to convert one of these athletic facilities here into a 400-bed hospital. It had 125,000 square feet, nurses' stations and everything else like that. And then we ended up opening it and closing it within a couple of months. It cost $6 million. And we opened and closed it before really we had any kind of need for it, and it was never used. So our hospital lost a lot of money, and we never used any of that stuff. The silver lining really was that from an operations point, the hospital did well, and that, you know, the emergency room was considered important finally, and we really had a low death rate, a low hospitalization rate. It was actually good that we never had to use that $6 million thing, and testing was easy once it was available. So in conclusion, kind of fear and confusion in the beginning of the pandemic really made us use a lot of resources and misuse resources that we didn't need. But at the end, we did have less deaths and hospitalizations, which obviously was good. And that's it.
Yep. Thank you very much, Linda. Due to the matter of time, we'll move into the next.
One minute for questions.
The 1 minute. Time is gone. Time is gone.
All right. Just trying to get my mic. There we go. All right. Thank you, Linda. So what we'll do is if we have some time at the end for questions, we'll open that up to the floor for any of our speakers. If we do go over time, we'll just have to cut into the question time now, unfortunately. It's my great pleasure to introduce our next speaker, David Oldenburger, who's an acute psychiatric nurse from Canada, Hamilton, University of Hamilton. He's going to be speaking to us about deployed in disaster, an exploratory study of personnel deployed into Ontario long-term care homes during the COVID-19 pandemic. And David's actually done a PhD in this area, so very excited to hear what he has to say for us. Thank you, David.
Good morning, thank you. Just one clarification. I'm from McMaster University in Hamilton.
Sorry.
And I'm working on my PhD studies. So I'm going to be presenting part of my doctoral studies. My name is David Oldenburger. I am a registered nurse. I work in acute psychiatry. I've also worked in the military for approximately 10 years. I'm a nursing officer currently. And what I'll be presenting is the experience of personnel who deployed in long-term care from the military and from acute care hospitals during the pandemic. And the reason I'm presenting this is that I deployed into another province that I'm not doing the research on in particular to, in Quebec, the second most popular province. And this was one of the largest deployments that the military has had since World War II in terms of number of personnel in the period of time that we deployed people in. And one of the other reasons that I'm doing this also is that I trained for combat, I trained for domestic deployments, I've trained for disaster deployments, but I've never trained to go in a long-term care home. And when I look at my colleagues, when I look at my friends in the hospital, also the military, it's also not what they were prepared for. Many of them had no long-term care experience, and personnel from the hospitals had never been deployed in another setting, nor were they often prepared to do so. So I don't say lightly that this was a disaster in front of all of you who might have experienced another disasters. But long-term care and COVID-19 in long-term care in Ontario and other parts of Canada was a disaster. For context, Canada has over 2,000 long-term care homes, which represents just under 200,000 long-term care beds. During the first and second wave, long-term care in Canada saw over 55,000 cases of COVID-19 among the residents in these long-term care homes. So approximately a quarter in the first and second wave between February 2020 and March of 2021, a quarter of the population in long-term care experienced COVID, and we had 14,000 deaths. Overall, this represented 69% of all COVID-19 related deaths in that period of time, for a population that represents less than 1% of our overall national population. So you can see here that COVID-19 has obviously been a disaster for many, but particularly in long-term care in Canada, it was a very impactful disaster for residents and staff that worked there. Now, in Canada's most populous province of Ontario, long-term care was experiencing a crisis related to resources, staffing, infrastructure for over 2 decades. But COVID-19 completely exacerbated these issues into the disaster that we saw. Oh, sorry. So as you can see here from some of the stats, in Ontario we had over 8,500 cases in the first wave, as well as 1,800 deaths. Some of the facilities, after they did a commission into it later on, found that they had 80% absenteeism. So in some cases, when I did my interviews, some of these staff were working with up to 20, 30, 40 patients per nurse. PSW is maybe 1 to 30 PSW to 30 residents. And obviously you're not able to provide care if you have 30 patients. So the care was very minimal, and it was the absolute basic needs. And many people died because of neglect, because of not being fed, because of wounds not being treated and not getting their medications on time. As a result, 35 long-term care homes went under temporary management, either voluntary or mandatory, by hospitals under the direction of the government, the provincial government, as well as the provincial government requested the assistance of the military and the Canadian Red Cross. And in total, the military deployed 275 personnel into long-term care, into 7 long-term care homes in Ontario, as well as the Red Cross deployed 200 personnel and I believe 40 long-term care homes in the province. So from my experience and also hearing the experience of my colleagues, I want to understand what we can learn from this experience with the questions of what they did, how they did it, and why they did it. I adapted the competency domains from the International Council of Nurses to develop a descriptive exploratory study and use semi-structured interviews to interview 28 healthcare personnel. And this is what I found. Looking at the bottom, you can see the demographics for the personnel I interviewed. So I interviewed 7 personnel from the military and 21 from hospitals. Of these 10 of them were nurses, and the 18 others were usually other healthcare professionals in allied health. And the deployed roles, so I interviewed both the personnel deployed as well as the managers who deployed to understand their experience in supporting those deployed and leadership aspects. So in total, I interviewed 11 management and 17 frontline personnel. And through my initial coding and memoing of the interviews, there's 4 key themes that were identified. The first one you see at the top is navigating the unknown. Ourselves experiencing COVID, you can think of the unknown in terms of how does this disease spread? First it's contact, then it's airborne, then it's droplet. So a lot of these personnel deployed during a time when we didn't know that much about COVID. We didn't know that it could be transmitted through ventilation systems. We didn't know how to properly sanitize and protect ourselves. People were being told to wear a cloth mask versus a N95. So that was a lot of challenges in terms of how to stay safe and managing that ambiguity. And then the next piece was about one's role and purpose. So personnel normally were deployed in some cases 1 day's notice or even less than 1 day's notice. And they didn't know what to expect. They've never been in long-term care potentially. They've never been in this long-term care facility. And the managers who were deploying them often didn't have experience or never worked in that setting either. So they really went in there, and many personnel just said, well, I did what I could, I did what needed to be done at the immediate moment, but often they had a challenge of what was their role, what was their purpose in being there that wasn't established until usually a week or a couple of weeks in. The next theme was a trauma and moral injury. So obviously they're going in there. Canada's a fairly wealthy country. We have a very established healthcare system. And then they're going into this setting where people have died because they haven't been fed. People have died because they haven't had wounds treated. They haven't had medications in time. People have been left unchanged for hours and in some cases days, not bathed for weeks. And you can imagine the moral trauma that somebody experiences. This is a disaster zone, but it's in their backyard. This could have been next door. For myself, I went to another province, but I had long-term care homes in my facility that experienced the same amount of death. One of the quotes that somebody said is, we ran out of body bags. That's how bad it got in a period of a couple days. And lastly, the topic came up of the presence of leadership. So the personnel deployed, they had leadership there, and they recognized the importance of that and how they felt they could trust their leadership. Versus The facility staff in some cases quit. They were sick or they were too scared to go in the facility. So they didn't have management's backing, and a lot of personnel in long-term care quit. And that's why we saw the 80% absenteeism. So I'd like to conclude with some basic lessons of what we've learned, and I continue to analyze the data, and I'm breaking down what specific lessons we can learn. But from my initial findings, the presence of leadership was really important for mitigating the fear and anxiety that people experienced. Also, trust is really important. So deploying with people you know, or at least deploying with people from a similar organization so you know how they work is really important. And that was one of the challenges of personnel who deployed, of the personnel who were working there, is many times they were agency staff or they were quickly hired and they didn't have that experience or that trust. And many of them quit because of that. Understanding one's purpose and role, and then being adaptable and flexible to managing that unknown. So thank you very much for your time. I understand that I'm probably a little bit over time, but if you have any questions, please come up to me after. Thank you.
Thanks, David. Do you have any questions for David? Oh, I'm out of time. Yeah. Right. Thank you, David. Thank you very much. So our next speaker is Niamh Cummins. Niamh is a public health lecturer with a research interest and interest in paramedicine and emergency medicine. Over to you, Niamh. Slides.
There we go. Thank you very much. Delighted to be here to present at WADEM. So I'm going to speak to you about clinician consensus on inappropriate presentations to the emergency department in the Better Data, Better Planning, or BDBP study. I'm going to address the elephant in the room first. The terminology around inappropriate, I don't agree with it. And I'm going to speak a little bit more about that later. So we all know ED crowding is a serious public health issue globally. In Ireland, we refer to this as the trolley crisis because of the fact patients end up on trolleys instead of beds. However, we don't really collect standardized data on this. So in the words of Lord Kelvin, if you cannot measure it, you cannot improve it. So in the BDBP study, we set out to investigate demographic and clinical factors influencing ED crowding. And we also looked at these from the patient perspective. So non-urgent ED attendances, which is my preferred terminology. So we know they increase demand on services. We also know they are somewhat unavoidable and they often occur due to service gaps, lack of evidence-based alternative care pathways. Some conditions are emergent, we know that, and some conditions or some patients still require advanced diagnostics. So unfortunately, we don't have an international consensus on what an inappropriate or non-urgent or avoidable attendance is. So the aim of this research was to develop a consensus across clinicians on this in Irish emergency departments. So in terms of methodology, this was a 24-hour census study. One of the limitations was it did take place during 2020, during COVID-19. So during the 24-hour period, we looked at attendances at 5 major emergency departments. We did select these based on case mix. There were some urban, some rural, some mixed. If we look at the 2 Dublin hospitals, they would have very different socio-demographic cases. In terms of the data, so we included participants aged over 18, Manchester Triage score 2 to 5, and we looked at patient reports and then surveys from the patients as well. We also did some qual interviews. So this is actually the 3rd paper which is under review from the study, 2 already published, and the qual paper is being analysed at the moment. So from the patient records, we put together patient summary files, which were then reviewed by our participants, the clinicians in this study. And we reviewed them for measures of appropriateness. I'm going to describe those now. So we asked them 3 key questions. Could this patient have been managed by a general practitioner in the next 24 to 48 hours? Was this an inappropriate use of ED resources? And finally, we asked them to rate it with regard to appropriateness. We then trichotomized this data into 3 groups then: inappropriate, neutral, and appropriate attendances. So this is what the chart review looked like. So we had 306 patients for the National Review Panel, which comprised an academic general practitioner and an academic emergency medicine consultant. They reviewed all of the charts. Then we did a subset analysis when they did not reach consensus, which was almost half the charts. And they were reviewed by an independent review panel, which included additional emergency medicine consultants, GPs, and an additional clinical nurse manager. Then for the local review panels, they comprise a GP and an emergency medicine consultant at each site. So our results. So you can see there for our first question about whether this could be managed by a GP in the next 24 to 48 hours, vast differences there. GPs 11%, emergency medicine consultant 38%. So our kappa value on that, our inter-rater agreement, was quite low. Similarly for attendance, a low enough kappa value again. When we looked at admissions then, when the clinicians agreed that attendances were inappropriate, the admission rate was 0. And then when they agreed that it was appropriate, actually 47% of patients were admitted. So that was interesting. However, there was no consensus on almost half the charts. Very busy slide, I'm aware, but just to point out, that there were significant differences across the groups on triage, presenting complaint, admissions, and length of stay in the ED. Then when we looked at the patient self-reported factors, one of the interesting ones for me here was whether they considered this condition to be an emergency or not. So number small enough in the inappropriate one there, but what we can see is that just 27% of patients who were deemed as an inappropriate attendance consider their condition to be emergency versus 55% of the inappropriate attendances. So patients know that this may not be the best place for their care, but the QAL data is suggesting to us that they are attending because of that service gap, because they have nowhere else to go. So again, when we look at the independent review panel, the subset analysis, a wide range again. So this is showing us how challenging it is to I suppose, characterise these presentations, even among, say for example, the 3 emergency medicine consultants. We still saw vast differences in agreement between appropriate and inappropriate attendances. In the local review panels then, interestingly, this was closer, the inter-rater agreement. So if we look, for example, at the appropriateness one, the rate there, I think, was 40% in one at the lowest site, up to 76% in James's Hospital in Dublin, which is the highest agreement levels. So this is likely due to, I suppose, local knowledge of pathways and thresholds for admission and so on. So our conclusions. So one of my colleagues, one of the co-authors on this study, made the observation that general practitioners are from Mars and emergency medicine consultants are from Venus, which I thought was quite interesting, but seriously, our conclusions are that, so clinicians from across healthcare professions agree that there is inappropriate use of the emergency department, but defining what inappropriate is very difficult. And there'll always be a cohort of patients that maybe cannot be defined because they're so complex. And this research once again demonstrates how challenging ED crowding research is and how there are no simple solutions. I do, however, have a few recommendations. So there is definitely potential for improvements in education, cross-training across specialities, potentially the establishment of regional forums for GPs and emergency medicine consultants where guidelines could be discussed. An actual clear definition, both nationally and internationally, on what a non-urgent / avoidable / inappropriate presentation would be helpful. And we really do need more evidence-based care pathways in order to alleviate ED crowding. Obviously, I'm going to say that, I'm a researcher. Some limitations. So the COVID-19 pandemic, as I mentioned, was ongoing during the study. There's local and regional variations. We also had a relatively small number of clinicians on the review panel. The admission refers to the index visit only, and we didn't look at follow-up, so admission is an imperfect gold standard. There's no substitute for having a patient in front of you, so there is obviously the limitation of the fact that the clinicians were just reviewing patient charts. And then obviously there's the international generalizability as well. So just some disclosures, no conflicts of interest, some funding from the HSE, thanks to them, and I'd also like to acknowledge all the staff in the emergency departments, all of our participants, and all of the team, a huge team and a fantastic team. So thank you very much.
Niamh, you can stay there for a minute. We do have a little bit of time for questions. Does anyone want to ask Niamh anything about overcrowding and the... Any questions? Sorry. There we go.
Quick question about the question in the research of can they be seen by a GP in the next 24 to 48 hours? Is that question assuming that they could get in to see somebody? Because I know at least in the American system, there are a lot of presenting complaints that could, if they could get in to see somebody, definitely be taken care of by a primary care provider. But in our system, we understand that it may take weeks for them to see somebody. So I guess I feel like if I were reviewing these charts just on that question, that would be a little confusing for me.
Exactly, it is making that assumption. And I suppose since COVID, we've increasingly seen that there's additional pressure on general practitioners and it is more difficult to get in to see a GP. But in saying that, one of the first papers from this study actually showed that the majority of patients came to the ED with a GP referral.
Okay.
Yeah. Thank you.
I have a question for you, Niamh. Is you mentioned that it'd be one of the suggestions to have more sort of cross-pollination in the training exposure. Do you think the current GP trainees that rotate through the emergency department, is their time productive? Is it effective? Do they need more time?
I suppose I'm not a clinician, so I will have to make that statement firstly. But I think that it probably varies a lot from department to department and maybe potentially university to university. So it's something that certainly could be looked at. I think something that we could do research on to find out that and answer that question.
Is there anyone else?
Time's up.
Yes? Okay.
Time's
You want
up.
to take one more?
David, can we hold that for afterwards? We will open up the floor again at the end for some questions if we have some time.
Thank you.
Great.
Thank you.
Thank you. Very good. We have our next speaker, Filippo Boroli. He's going to be speaking to us on the development and implementation of prioritized care in a tertiary hospital intensive care unit during the COVID pandemic. So, Filippo, the floor is yours.
Thank you. Perfect. So, we felt like being in a humanitarian mission at home, and so that's how we adapted. Our ICU, I'm Filippo Boroli, I'm coming from Switzerland. I'm an anesthetist and intensivist in the Geneva University Hospital. Our ICU before the pandemic was a 32 beds ICU, 2,200 patients by year, with a high number of human resources, as seen by the bedside nurse to patient ratio, 1:1, and in the worst case scenario, it went up to 1:2 patients during the nighttime, and a high rate of specialized ICU nurses, as you see. We didn't have a plan. When we were hit by, when Bergamo was hit by the COVID, I just had some colleagues from there that called me and that said to hurry up, you need to have a plan because the COVID will hit you. So actually we had a plan, but it was the H1N1 pandemic plan that it was never implemented, never tested, so we had to start from scratch. We developed our security model that allows us to identify the five biggest threats to activity shutdown. And those were human resources lack, activity overload, medication errors, pressure sores, and hospital-acquired infection. The last three would make the length of stay of patient longer, so we wouldn't be able to admit more patients in our ICU. And we started to plan a strategy to control, recover, and mitigate each of these threats. Finally, we went through and we assumed that like all the basic needs like food, electricity, finance, we wouldn't face any lack of them. We went through the first two waves, I would say quite well, and we were getting ready for the third one, having some really bad news from the UK that was hit by a huge and a bigger wave than the two previous ones. And so we started to plan for the worst case scenario, and we asked ourselves whether we had really managed the five threats. Why we asked this question? Because we felt that our staff, as everywhere else, was exhausted. But why was it exhausted? Probably because of the pandemic fatigue, burnout, and they told us we feel guilty. Come on, guilty. Why? We might have the answer. On the left side of this slide, you see the quality that is asked from the society. The society wants us to provide the best ever care, ever night, during the day, weekend, even if we are on holidays. Then COVID came, and what we have seen is that quality lowered down and fluctuated during, depending on the local condition. And we were not ready about that. People felt guilty not to provide, not to have provided the same quality as normal time. So to protect our staff and to lower this feeling of the guilty, we defined a new framework, speaking with them, what was acceptable for them, and I'm not talking about society, but for our staff, and what wasn't unacceptable. What was acceptable in the worst case scenario was to treat up to 4 patients at the same time. The patient had to be comfortable, clean, with an IV line, and eventually an endotracheal tube for ventilation. What was unacceptable was to leave the patient dying by himself. So we decided that in this case, probably the ICU would change mission from critical care to palliative care. If we couldn't provide staff with all the material and stuff to stay in the acceptable part, we would change our mission. And this framework reassured our staff, saying, okay, we know you are suffering, you are doing your best, and we will guide you through the pandemic. We needed a new organization. We call it the cell, and the cell is its main characteristics are that the caregiver becomes the team. We didn't want the nurse to take care of the patient from A to Z, but the whole team would take care of all the patients in the unit, and we divided the patient in activities. So we listed the activities to be done during the day, and all the team would help each other to do the activity. Everything was coordinated by 2 experts, 1 nurse and 1 ICU doctor. How we put it in place? Through huddles at the beginning of the shift, and the objective was, first of all, to let the team members know each other. Second, to make them feel safe. Third, of course, to organize activities. And how do they do it? They actually present themselves, first name, experience in ICU, and operational level. I feel bad. I won't be able to do anything today. I need help. Or I'm full energetic, and so I can be a resource for everybody. Then the 2 coordinators would prioritize and organize activities, and at the end of the huddle, they would ask themselves, will we be able to do all the activities that are planned? If the answer was no, they would refer to the management to ask for help and new resources. How did they prioritize activities? Actually, I'm sure you know this table. That's the Eisenhower matrix, and we use it, that you use for your personal agenda, and they did the same thing. And in the bottom left part, you have the case that admitted that abstention of one or more activity was something recognized as a need. We wanted to lower the pressure on our staff. We implemented it through a 2-month pilot phase. We trained lots of colleagues through some crash CRM course, a 2-hour course, and we were able to treat and admit in this cell 70 patients, and most important, we have no critical safety issues. And you see on the right side the prioritization of the activities with post-its. So my take-home message, in our setting, human resources were the most important / limiting factor in the long-lasting pandemic. Planning for the worst-case scenario helped us to set new care boundaries, and probably and hopefully the prioritized ICU care could allow to treat the most while attenuating staff burnout. Thank you very much.
Thank you very much. Thank you very much, Filippo. We can take one quick question. Okay.
Can I ask? So, Filippo, with regards to making staff feel safe, I mean, they have to be quite vulnerable to share. How am I feeling today operationally? How did you ensure that safety for them, that they were able to be that vulnerable?
Actually, in the first huddle, it was kind of difficult, as you say, but then they feel free to speak, actually. And the fact that they would spend all the shift together, the feeling of being a team felt grow stronger and stronger. And so you would be surprised at what people can say in the morning, like, hey, I'm KO. I can do anything. I came because I had to come, but I useless today. And so the management would also detect this person, help them personally.
Okay,
that's very good.
Thank you, Filippo. Thank you very much. And our next speaker is Maiko Yoshida. Maiko is from Chiba University, Chiba, Japan. She will talk to us use of post-mortem computer tomography in disaster victim identification. Thank you.
Thank you, Chairman. Good afternoon. Already it's afternoon. Maybe good afternoon, ladies and gentlemen.
Yes.
My name is Maiko Yoshida. I'm a forensic radiologist working for the Department of Legal Medicine in Chiba University in Japan. And I imagine most of you are not familiar with the topic, so I strongly hope you are interested in. This research is supported by the Japanese government as challenging research exploration. So let me start from the backgrounds. Identification of unidentified persons during peacetime in Japan is generally performed by objective means, such as a dental chart, fingerprint matching, or DNA matching. Conversely, in large-scale disasters, identification is usually performed by non-objective means. For example, in the case of the 2011 Great East Japan earthquake, up to 90% of the bodies were identified by non-objective means, such as facial features or their belongings, which resulted in misidentification in some cases. At present, the situation remains unchanged. In contrast, a method called Disaster Victim Identification, DVI, is a global standard method recommended by the International Criminal Police Organization, in which a multidisciplinary investigation team collects objective information such as dental findings and DNA for identification of bodies. In recent years, there has been a movement to use postmortem computed tomography in the DVI process. Thus, participation of imaging specialists such as radiologists in the DVI team is expected. So the purpose of this study is to identify individuals by comparing antemortem images and postmortem CT in autopsies of unidentified bodies during normal times. So here's a theory using PMCT personal identification. The sinus shape is considered to be unique to each individual person, and the shape of the bones, including sinuses, is thought to be almost permanent in adults. And in addition to normal structures such as paranasal sinuses, the following elements are available: normal mutations and new and old lesions such as fractures, traces of treatment surgery. Thus, in many cases, it is possible to identify most bodies by searching for as many characteristic matching points as possible and confirming that there is no contradiction between the presumed person and the body. Here's the materials and methods. The police asked us to identify 20 unidentified bodies at our institution. The identification was performed by comparing antemortem images of the presumed persons with PMCT images taken prior to autopsy. And PMCT were reconstructed on a workstation to create images that were appropriate for comparison with the antemortem images. And image interpretation and comparison were performed by 2 certified radiologists with experience in interpreting PMCT, including me. And a PMCT, we used a 64-rod detector CT. And here's a process to create PMCT images for comparison. The PMCT images were modified on a workstation to enable comparison with the antemortem CT images like this. Here's the result. It's a very busy slide, but the point is, in all cases, no fingerprints information, and then no dental findings. And as for DNA, in some cases, DNA was planned to examine, but in most cases, there are no family members, so the police did not plan to DNA testing. And so in all cases, we concluded that there's no contradiction between the presumed person and the body. And I would like to show you several actual cases from next slides, but it includes the dead body's photo. So if you do not want to see it, please look down and just listen to my talk. This is the first case, a highly decomposed body found in an irrigation ditch. The presumed person was a 72-year-old woman with dementia and a history of wandering. And in this case, no medical records of dental treatment, no criminal records to match fingerprinting, and no family members to match her DNA, but she has a surgical marks on the head. And this is the actual comparison image. So the metallic clippings of 4 intercranial aneurysms compatible, and the post-operative changes at the frontal bone are compatible. The shape of the sinuses are compatible, and therefore we concluded there was no contradiction. And this is the second case. The skeletal body found in a forest. The residence registration card beside the body indicated that the presumed person was a man in his 60s. And in this case, also no medical records of dental treatment, no criminal record to match fingerprinting, and no family members to match DNA. A medical record for the presumed person was available. And this is the actual image of comparison. And the shape of the skull, paranasal sinuses are compatible, and the localized osteosclerosis, what we call bone islands, at the left femur and the left pubic bone was compatible. So there was no contradiction. And this is the last case. A highly burnt body found in a house that had burned. The presumed person who lived in the house was a man in his 30s. He had been receiving outpatient treatment for epilepsy. In this case, impossible to examine the teeth and impossible to examine his fingerprints because both hands were burned badly. And the DNA testing with his family was planned, and also the presumed person had medical records. Here's the actual image of the comparison. The shape of the skull, paranasal sinuses are compatible. The vertebral shape with very little osteophytes is compatible. And the fracture of the left 9 to 11 ribs are consistent with the old fractures on PMCT. The position of the 3 impacted teeth in the treatment scar are compatible on the dental images, and there was no contradiction. So let me move on to the discussion. Confirmation of the presumed identity of bodies by comparing antemortem and postmortem images is especially useful when other methods have failed. This method should be useful in close disasters such as airplane accidents with passenger lists. However, implementation in open disasters may face challenges because the database of antemortem information, including image data, has not been established in Japan. So let me conclude. The usefulness of individual identification by comparison of antemortem and postmortem images was confirmed. In the future, this method should be useful after disasters as well as during normal times. Thank you very much for your attention.
Okay, cool.